Welcome everyone. Today is a really special day for us in CESAM. We are developing a sustainable interprofessional community, and with this aim in mind, we have changed our name. So now we are Society for Simulation in Healthcare. 2020 is the nursing year, and we would like to keep that momentum and strengthen our nursing network. Nursing Simulation Interest Group has just born in our last conference in Glasgow, and since then they have been working a lot with a lot of enthusiasm and empowering European and worldwide nursing simulation community. And as I said before, it's a really special day because all this effort is going live now with this YouTube streaming that I have the great honor of moderate. And what we have prepared for you. So first of all, Alvaro, Mandy, and Kasia are going to share the nursing simulation interest group ideas with you to know and maybe considering joining them. And after that, we will have the session. I mean the Pam Jeffries, the evolution, essentials, and future of simulation-based education, followed by some questions and answers. You will have subtitles in Spanish for this session. Before starting this great content, I would like to thank you all because you are so busy or it's so early in the morning in some countries. I know in Latin America it's really early, lunchtime in others, maybe in Europe. Maybe you are in the middle of a simulation, I hope not, but or maybe in between meetings or at the end of a really long day, but you have decided to be here with us. So that's meaningful. We appreciate it a lot, and we would like to thank you for being here. We will have a chat for you to comment during this presentation, and we will answer at the end. So let's start with nursing sake.
Hi, my name is Alvaro from Spain, current chair of the CESAM Nursing Special Interest Group, which we have called Nursing. And I would like to take this great opportunity to welcome all of you to the new CESAM Online and to present this group, Nursing. Nursing was born in the context of the 2019 CESAM annual meeting in Glasgow, where with the support of CESAM, a group of simulation enthusiasts from 10 different countries gathered together to start this trip through simulation and education. Nursing, born aligned with the aims of CESAM, with a mission to provide nurses and other professionals that educate through simulation a safe interprofessional environment, based on collaboration and networking through the globe. Nursing has a vision at the end of the horizon of this educational trip to transform practice by leading, promoting, and supporting change and excellence through simulation. Hope to meet you all soon, and I hope that all of you help us to build up this community together.
Hello, my name is Amanda from the United Kingdom, and it's a great privilege to volunteer as part of Nursing Special Interest Group. The mission, as you've already heard, is to promote nursing within CSAM and the wider simulation community. And how can we do this? Well, it's about facilitation, collaboration, networking using things like Twitter, Facebook, LinkedIn, and also at all the different Simulation Society meetings. So come join us, come be a part of nursing.
I'm very happy to be here with all of you. My name is Kasia, I'm from Krosno, from Poland, and I'm coordinating a medical simulation center for nursing students. I would like to take this opportunity to encourage you, nurses, simulation enthusiasts, academic teachers, to join our community called Nursing Group. It's a great occasion to exchange our experience, knowledge, and ideas on how to educate and share through simulation, and how it can help to educate with nursing education, especially in this hard time with COVID-19, where face-to-face simulation could be compromised. We can talk and learn from each other from all countries around the globe. You can also follow us on a Twitter account called CESAM Nursing. and register your interest to participate in our activities of the following keyword: join nursing, and help us to build up this community together. Thank you. Join us!
So where is now? And now it's Pam Jeffries. Pam is professor and dean of the George Washington University School of Nursing. But for me, it's a referent, a real one. Working with her, preparing this session, I see the real Pam, a nurse who has an incredible and solid background and always have served for the nursing community and patient safety. I've read yesterday a Twitter saying we all were expecting a really good session today because we have been reading Pam for the last years. And today we have the great opportunity of having her here. So thank you in the name of CESAM, Pam, for being here with us. And thank you in the name of nurses all around the world to share your work with us.
Hello, I'm Pam Jeffries, Professor and Dean of the School of Nursing at George Washington University in Washington, D.C., USA. Thank you for having me speak at the CESAM conference. I'm very thrilled to do so. Today, I'll spend time talking about the evolution, essentials, and future of a simulation-based education. The objectives for the presentation include describing the importance of clinical simulations, educating our health professionals, discuss the evidence and best practices around the use of clinical simulations when integrating in a health profession curriculum. Also, I'll discuss future concepts and direction of clinical simulations. And lastly, demonstrate different exemplars of incorporating virtual simulations in a simulation program, particularly since we've all been in this pandemic time, right? We've had to move to virtual quite a bit. So to begin with, in the simulation world, as probably many of you know, I'm a simulation advocate. I believe simulations it's a new clinical redesign, and they're very important to incorporate as part of our clinical education, because simulation provides that safe, non-threatening environment where our nursing students, our health professional students can practice safely and also get feedback from the instructor through the debriefing. So simulations has gained momentum, I would say, over the past decade or so. I look back from my initial work clear back in the early 2000s and how it has exploded and grown. And we've learned a lot. So today I'm going to bring you some of those best practices and some of the evidence from some of the studies. But in the US, there's been two influential drivers on where we are with clinical simulations today. One, through the Journal of Nursing Regulation, they have the study, and you can get a free download. It's about 74 pages. You can go to ncsbn.org to get the study that I'm going to talk about. It was a large multi-site 10-school study in looking at simulations and how we can substitute real clinical time with simulations and some of the best practices and the outcomes from that. And I'll go over it just very briefly. The other driver for clinical simulations, again in the US, has been, it was a IOM report, an Institute of Medicine, and it can also be downloaded free. It's called The Future of Nursing, Leading Change, Advancing Health. But they talk in this report, and it was a driver, a 10-year plan, and now we have another one coming in 2020, 2030. But the driver was talking about using technology and innovations in clinical education as well as nursing education. So using both of those documents, they were seen as drivers. So I mentioned the big NCSBN study. That stands for National Council State Board of Nursing Study. Nursing Council, NCSBN, is our big driver. They grant our licensure to become an RN, a registered nurse. Anyway, back in 2014-15, I was one of the consultants to lead the study, along with NCSBN and some other researchers. And I want to bring you the results because the results have had impact on how we today are using clinical simulations in nursing education in the States. So in the study, there were 10 schools of nursing, as I said, and we had 3 arms of the study. One was the control, business as usual. Another arm of the study was 25% across 7 courses was substituted by simulation. So in other words, if you had 100 hours of pediatric clinical experience, so for 25%, 25 hours would be spent in the simulation lab and 75 would be with patients. The 50% was another arm, and that arm was 50%, meaning 50 hours in the simulation lab and 50 hours in real clinical time. So those 3 arms were studied, and the question was, are we harming students if we substitute simulation for real clinical time? So here are the results with that. And as you can see, up to 50% simulation can be effectively substituted for traditional clinical experience. So we got the evidence. We're not hurting students. This was amazing. We already knew it, but we had to get the evidence because we had a lot of non-believers or naysayers. Also, second point, 50% of simulation can effectively be used in various programs in different geographic regions. Our 10 schools of nursing were west, north, south, across geographically in different areas, in urban settings, rural, private, public universities. In addition, 5 were for baccalaureate programs and 5 were for 2-year community colleges. Also, our nursing board pass rates, and we have to take a board test to get licensed. Whether the students were in 50% simulation, 25% or control, they were unaffected by the substitution of clinical simulation. So that's good news. Again, we weren't harming students, and we can substitute simulations for the real clinical time. All 3 groups, the control, 25 and 50%, were equally prepared for transition to practice. And that's an important part. If they were in simulations, we didn't harm them, they weren't held back, but they could transition just like the control group that had minimal simulations. And what I'm going to bring you today, some policy decisions regarding the amount of simulation in nursing was dependent upon best practices in the simulation. And new policies and guidelines have come out since the study. And that's what I'm going to bring the audience today. So maybe you can glean some of the best practices using the evidence. So when the study was conducted, there are certain factors that were outlined for success. And I bring you this information because I would love to challenge you to consider this if you're not using these factors for success when you're developing your simulations and implementing them in your nursing programs or health profession programs across the nation. So we'll talk about each one, the INAXO Standards, the plan framework, high quality simulations. Also debriefing was a method grounded in educational theory, and faculty or instructors were trained on how to debrief. And then we had a trained and dedicated simulation group of faculty or instructors. Let's talk about the theory first. In the study, the study was grounded in theory, and we used what at that time it was the NLN Jeffries framework with different components on how to develop, implement, and evaluate a simulation. And since 2015, now it's become an NLN Jeffries simulation theory. There is a monograph you can look at, but that's the theory and the whole study. And I would advocate that if you don't use NLN Jeffries simulation theory, but another theory, Kolb's experiential theory, the constructivist learning theory, there are theories that we can ground our simulation work on and help to build better simulations. INAXO Standards. INAXO stands for International Nursing Association of Clinical Learning. And those are very, very important. Clinical simulated learning, the S is left out of there. But you can read the history of INAXO. INAXO is an organization. It's a global international organization for nurses in clinical simulation. And you can see the trajectory of the history starting clear back in 2011, where they had the first edition of INAXO Standards, now they've got the 4th edition coming. But these standards are standards that are written to guide our work. And why are standards important? Well, they're important because if I'm using the standards, say in the UK and in Spain, you use the standards, and we can start comparing our work because we're using the same standards. So it's not all over the place, it's not random, but there's a basis for the work, and we can start, it's easier. Even using theory, when we use theory, we can start testing parts of the theory, but using the standardized approach. Overview of the INAXO standards: they're healthcare centric, they're grounded in evidence, and there's a common template when these standards have been built with references and criteria. And I'll show you, here are the list of standards. And these are free. If you go to INAXO, just type INAXO standards and they will come up. And there's a booklet, or you can see a free downloadable booklet, if you will, on each standard. And the standards are about simulation design, on how to write outcomes and objectives, one on facilitation, one on debriefing, participant evaluation. You can read the list. Anyway, those are there. But if you ground your work in these standards, then you can replicate easily. You know, you're basing your simulation development and implementation on standards. So I challenge you to use these standards if you're not already. Also, from the evidence, when I'm going back to the study and saying, you know, let's look at the evidence of best practices. This is what I hope to bring to you today. From the evidence, there were implications for schools of nursing, implications for the clinical organization. So what are these implications? What are the findings to help guide policy? What are the standards that are needed to integrate a simulation-based curriculum into your nursing program? And what should we consider as a group of faculty or instructors and administrators to address a simulation-based curriculum? So part of the standards and guidelines, it was published in a paper. And I will be glad to send this to the SESAM group, so you have the paper and it can be disseminated. But the National Council State Board of Nursing created guidelines for simulation. We got together as a blue ribbon panel and produced this paper. And the evidence is based in this paper. The evidence was used to write the paper. So we established simulation guidelines based on the evidence, resources. We created a faculty preparation checklist. So when instructors use simulations in their course or build a simulation-based curriculum, there is a checklist. Also, if you're integrating simulations in a program, there is a preparation checklist. These are some do's and don'ts that you need. And all these guidelines are meant to be helpful to the educators using simulation. Another implication were regulations for simulations. So in the United States, we have state regulations. We have 50 states, 50 Board of Nursing regulating each state. So the states, to regulate how we use simulation in our universities, in our nursing programs, state boards of nursing set guidelines or regulation. So I'm giving you an example. This happens to be from the state of Arizona. You don't have to remember that. But here's some of the standards. So in other words, if I lived in Arizona and I'm using simulations in my nursing curriculum, these are the guidelines I have to go by because I'm an accredited school, and nursing students in Arizona will set for the nursing boards. So they say we need to use INAXO standards. We need to use simulation scenarios that are integrated in the curriculum. The simulation facilitators, the instructors, they have to be prepared or developed. They just can't go in and say, I don't know what to do, but they're developed in simulations. Also, students participating in sims should have equal opportunity to perform the role of nurse, not just observe all the time, but let them be hands-on in the role of the nurse. Also, there needs to be adequate resources. If you're going to have a simulation-based curriculum, objectives need to be written, and also we need to evaluate the program. Is it working or not? It doesn't do any good just say, well, we've got one, but we don't have the outcomes and we're not measuring. So those are guidelines set by one state, but many states are similar. Other implications from the study that we are abiding by based on the evidence and using practices. So use of simulation framework is necessary. And I talked about the NLN Jeffries simulation framework. That was important. Second, you can create or you can purchase simulation scenarios. It doesn't matter. You don't have to make them all up. You can buy them, you can purchase, but they have to correlate with your course concepts. Also, use a standardized simulation template when developing simulations for consistency. So if I'm developing simulations for med-surg, I'm developing simulations for pediatric or maternal health, I can use templates so the simulation design is similar across all courses. No need to diversify the simulation template because you're going to write objectives. You're going to have how the scenario unfolds and problem-solving components. And also encourage to adopt the theory-based debriefing. In other words, you need to teach your instructors how to do debriefing. That's very important. Not everybody can do it. It's an art. So they need to know the structure for debriefing and be developed or trained in that area. And then you can also consider other integrating major concepts in the simulation. For example, certain communication strategies. We use what's called the SBAR. SBAR is when we communicate, I'm sure you've heard of that, but situation, background, assessment, recommendation. So, or we can incorporate cultural competencies in each scenario. What would that look like? Simulation training, skills development. As I said, that's going to be important. That's another implication because use a simulation expert to conduct the training. So anytime when someone's building a nursing integrated simulation program at your university or for your nursing program, get some skilled trainers. I know I've done train the trainer many times, but faculty instructors need to be developed. Also, a dedicated time needs to be set aside for skills training. What does that look like? Is it a workshop? Are there webinars? Now we're no longer going to virtual conferences. CSAM right now is an example of you being developed in this area. And set an education training agenda. Outline what that would be, what are the competencies you want to achieve. And I'll talk more about a faculty development opportunity soon. Also, selection of educators, faculty. I strongly urge you, and I've done this, is to develop a simulation team. Back a decade ago, I used to train every educator in simulations. Everybody's gonna learn this. But then it's a revolving door. Some leave, some aren't with the university very long, and some don't even embrace the use of simulations. They didn't like it. So now I have a simulation team. I have about 5 on the team because we have a big program. And they're trained and they help run the simulations. They help get the equipment ready. They set up the room. They can be the voice for the simulator, for the simulated patient. But the team runs the simulations. And then the instructor can come in and help with the debriefing. But if I've asked all the faculty to learn about the mannequin and how to set up SimMan or Virtual Ann or anybody else, it's problematic. You got a lot of development and people sometimes don't know what they're doing. Also designate a simulation coordinator or manager for this team. There needs to be a leader of the group that can evaluate and prepare and orient those the sim team and to work with our instructors in the course. And overall, I like to develop a simulation learning community, create an online platform. We've created simulation advisory council, and the sim leader works with the advisory council, which is comprised of faculty, instructors, because if we want to order equipment, if we want to order new simulators, or we want to share best practices, let's get that team together. So that's another piece of advice or implication coming out of the study. So here's, when we talk about faculty development, I want to bring this to your attention. This is a MOOC, a massive open online course. It's through Coursera. You can see www.coursera.org. This is free faculty development opportunities. We have developed 7 modules, 7 online modules. We have approximately 7,000 in our MOOC, George Washington University School of Nursing. We had 7 module authors. Anyway, it's free. You can go in and take it free. If you actually want a certificate of completion, Coursera says you can sign up and get it for $49, but you don't have to have this certificate if you don't want to. It depends on your institution. But for our instructors using simulation in our nursing program at George Washington, we have required all of our faculty using simulations to go through these modules. And it's helpful. It sets the background up. There's a module on debriefing. There's a module on setting up a simulation. There's a module on the NLN Jeffries theory, one on integrating in curriculum. So you can see those modules. Again, go to coursera.org. Formal recommendations in summary for the educators and regulators. 1, formally trained faculty or educators in the simulation pedagogy. We want to use a theory-based debriefing method because it's an art. They need to be trained on debriefing to get the most bang for the value of debriefing, because that's where students learn, in the debriefing. That's where they connect the points, theory to practice. We want adequate numbers of simulation instructors to support the learners. You can't work with a skeleton crew if you got a lot of students. And of course, the resources and supplies need to be realistic for what you're doing. So moving on, latest trends and future activities. What are we doing? Looking a little bit ahead. So in the States, what I see, we are increasing regulations and standards. No surprise, United States, we're always looking at all these standards. But due to the study, there were implications for the evidence for pre-licensure or RN programs. So some of those policy implications are already shared for you in programs across the state, where you have to use INAXO Standards, where you have to have an evaluation plan. Instructors have to be trained. Those are standards coming across the states, and they're checking to see if that's done. So it's not higgledy-piggledy. We're just not randomly doing what we want, but there are some standards and control over that. And as you can see, those requirements are changing, even a plan for evaluation. Another change happening now and in the future, you're going to see an increased usage of simulations in nursing curricula and in healthcare organization. Again, I tout as the new clinical redesign for clinical education. We're using simulation as a promotion of the culture of safety. We're trying to promote safety and safety competencies. And what better way through simulation where they can practice in a safe, non-threatening environment before they go out and work, before students go out and work with our real patients and communities and families. So simulations, they, to me, provide a better way to transition to practice, preparing a better workforce. And also with the global pandemic, we've seen more and more use of virtual simulations has had to be used, both in our graduate area as well as our undergraduate. I'll talk more about that in a minute. Another trend are simulation platforms. There's an evolution based on needs, accessibility, and flexibility. During this global pandemic, VR, use of simulation-based, computer-based simulations were big. Adaptive learning, use of 3D, use of artificial intelligence. Those will continue to grow and get bigger, because if you look at healthcare, the technology in healthcare, point of care, using artificial intelligence, that's ahead of what we're doing in education. We're trying to look now, what are those AI competencies that need to be built in our nursing education programs? So nurses and other health professions know how to deal with the data analytics. In healthcare, soon we're going to not only have our primary care provider, but we will have an AI specialist dealing with the diagnosis and working with the consumer. So that's on the horizon, it's happening now. Other future trends is value proposition. We tend to frame simulations around quality, safe care. We're not doing simulations just to do it, but it's immersive, it's experiential. We felt we are providing and training and getting better practitioners to transition to the workforce to provide high quality, safe care. So the movement with simulations is more interprofessional simulations, building on team, building on quality teams, and promoting safety and quality. Also more, we've seen simulations over here in the US more in the undergraduate, more in pre-licensure, but we're also seeing more increased usage in advanced practice nursing in the graduate area, whether that's in midwifery, whether that's in the nurse practitioner area, but more and more simulations are being created and embedded in the curriculum. And that will only keep growing because, again, we want to develop a prepared workforce. Also with the pandemic, our nurse practitioners had to do virtual simulations a lot to account for some of the practice clinical hours because we couldn't get all of them in. So in order for the student to progress, some of those simulation-based, computer-based simulations were counted for their course, which is completely fine based on our standards. Also, you're going to see more competency-based simulations filling this need. In other words, immersing the students into a competency-based simulation. Did they get the competency? Because we're moving more to competency-based, not just amount of 700 hours in a program, but have the learners, the nurses, the health professionals, can they demonstrate the competencies needed? And usually testing those competencies, by the way, are through simulations. So with the global pandemic and what we've been doing, clinical education for us, and I imagine for you over in Europe, we moved to a lot of virtual simulations, a lot of virtual clinical learning because we couldn't get in the hospitals. Hospitals had COVID patients. Student nurses weren't allowed to come in. Only the priority was caring for COVID, right? So with this, what were we dealing with? We had to look for alternatives for clinical education so our students could complete and progress through computer-based simulations. Why? Because of COVID. Our learners all became remote. They had to self-pace. Sometimes it was teacher facilitated. And we worked collaboratively to get the students' education continued for instructional continuity. And there were various approaches, many using simulations and other types of strategies to get our learners engaged in clinical education when they could not go to the hospital. And I'm sure that happened across Europe as well. So at this time, I'd like to give you a few strategies of what we were doing. And I would love in the Q&A to hear about some of your strategies. So looking at virtual simulations, there were lots of products we could use. And I'll give a shout out to some of the vendors because they gave many of the schools a 3-month trial. So it was free because once we moved from face-to-face to a virtual, many didn't have the finances or the budget to do that. So kudos to many of our vendors. They said, you have a 3-month trial, so please use. Or many said, you have a 50% discount on this product during this time. So they were trying to make it easier for us to provide instructional continuity with our students. But there were a lot of virtual simulations through vendor Shadow Health, and I'm not promoting in a vendor, I'm just giving you examples. One was the AT, Assessment Technologies Incorporated. They have lots of video based simulations and debriefing. VSIMS, it's the virtual with the simulations. It's Laerdal and Wolters Kluwer. Those also have debriefing and you get a score on those, and they have it in med-surg and maternal health, pediatrics, and those. Aquafire was a free one, lots of video sim-based simulations. And whatever we did when we used a vendor model, such as I gave, then our faculty, our instructors would have a facilitated debriefing. We felt that was essential we have the students, we assign them, to use, the VSEMs. And even though there was a debriefing with a feedback component, many times, many of our clinical instructors wanted to set up a synchronous time where they could debrief the students. Say they've done 3 virtual simulations, now let's debrief. What did you learn? What questions do you have? So there was always that human interaction through the facilitated debriefing. Even though it was virtual, we could still capture their questions and set any misperceptions correct and all that. Then I also had teachers using movies. I had a psych mental health faculty used a movie to play the movie, and students could get it on Netflix, so there was a free download of the movie. Then they would come on and debrief the movie on what that might be, or in geriatric, a component on geriatric nursing, and there's several on that. So what did that look like? When I think of the movies, I think one of my faculty used The Joker, the movie that was out there. And then they had the students not only debrief together and answer questions, but then they had to write a care plan on one of the health disruptions they might have seen in that movie on that certain actor. Or they had a 1-minute paper on, this diagnosis that they felt, and write a paper, write the highlights that was very brief. And then there were synchronized sessions to talk about that. So that was a novel way, again, trying to get the students engaged, because we were virtual, we couldn't be in class with them, but using movies or things like that. Also, during the time to provide instructional continuity, we used telehealth scenarios. There's some free telehealth scenarios out there. Also, we hired a standardized patient. Many times the patient and a nurse could come in and videotape it and then display it to our learners, and asking them what they would assess through telehealth. And as you know, I think telehealth has become a game changer during this COVID time, because that's how patients were being assessed and diagnosed through COVID through their own primary care providers. So telehealth is a big one. It's not going to go away. It's one I think we need to establish competencies in not only just nursing education, but across the health professions. And you're seeing more and more of that now. And then lastly, just another strategy or example, through the GNSH, that stands for Global Network of Simulations in Healthcare. And I am part of GNSH. I'm actually a board member, so I'll be transparent with that. But we developed what was called a 30-minute campaign for team engagement. And that was to promote quality, safe care. If you go to www.gnsh.org, there are 16 free cases. I'm going to talk to you a little bit more about, just very briefly, because this is a whole presentation in itself. But through GNSH, we wanted to promote quality patient care. And to do that, many times we felt communication among the healthcare providers, that's part of the problem. If you look at the #1 cause of errors, many times it's communication, because there's a breakdown in a handoff or communication and training, whatever that might be, that leads to, sentinel type of events. So we created a model for this, we call it a 30-minute campaign, weekly campaign. And the model was to go into healthcare organizations. We were going to test this campaign in the organization where they can use this, where they see you go through the campaign, there's cases, 16 cases, and you have a healthcare team and you go through the case. And at the end of the case, hopefully you identify some of the concerns, the communication issues, systems issues, but you're working as a team. So the intent was to go into a healthcare organization. However, during COVID, in the academic world, we used many of these cases. They're patient cases, and they're real patient stories. And they're, they pull from the heartstrings, they're real because they're true. And some are from the UK, by the way. They're not just all US centric. And the intent is to develop and strengthen team communication and then identify system issues. With team engagement, we felt we were creating this safe space. There's a high frequency, low dose if you did it every week. But in the academic world, of course, you were bringing it into your classroom, wherever. But the main thing, these cases are free. And overall, the whole goal is to improve patient outcomes and the culture of teamwork and collaboration. So here are the 16 cases. And again, if you go to gnsh.org, you will see these. But I want to point it out, we have 4 cases in sepsis, 4 cases in medication errors, 4 cases in healthcare associated, healthcare or hospital associated infections, and then 1 on care teams. If you have staff issues, care teams, whatever that might be. And you can play those snippets. For example, if I taught a patient safety course, I would begin every class with one of these videos because they're all about patient safety. And again, you can run through the snippet. There'll be a patient story, there'll be a debrief, talks about the clinical care, system issues, and you can run through your class of students with these. So I challenge you to look at these. Again, they're free all through GNSH with all the goal intended for high quality patient care. So with that said, I want to swing back because important as we deliver virtual simulations or face-to-face simulations based on the evidence, our instructors or faculty need to be developed. This is back to that MOOC again, but it's free. I'm trying to bring you some free resources because I don't know about you, but my budget's constrained. I've had cutbacks majorly in our program at our school. But again, the intent, if you want some free instructor development, it's here. So overall, here's references I provide you. And I want to thank you for letting me present at this conference. I appreciate it. And at this time, I will open for Q&A and take any questions or comments. I would love to hear from you. So on that note, thank you so much.
In our chat that we would like to share with you. So let's begin with some questions. I think they are really interesting and more in this COVID time that we are living. So first question is from David Grant, UK. He's asking about if you find, the studies has found that you could replace clinical time with simulation-based education, and what kind of impact has this replacement?
Okay, so great question, whether to augment with simulations or to replace. We have those discussions in the US, and many times in pre-licensure program, I'll just say for the RN getting their baccalaureate. Across the US, sometimes clinical sites are very difficult to get. So many, and particularly during COVID time, but our boards of nursing that are regulated by every state, they are letting us supplement clinical time. So for example, if I have 700 clinical hours, they may, depending on the state, they might say that we can substitute real clinical time patient care with up to 25% simulations across the curriculum. Every state varies. Sometimes it's 25%. There are some states that say 50%. Even the state of Ohio will say you can do 100% for pediatrics and maternal health because in some of the rural areas, they can't find sites. And we compete with medicine and schools of nursing in 2-year programs, 4-year. It's very, very competitive. As you saw in the NCSBN study, the National Council, that's what we were doing. If we did substitute up to 50%, up to 25%, what were the outcomes? And the outcomes did not hurt students. So we do use the word substitute. In the graduate education now, there's questions about augmenting. We do augment in our nurse practitioner programs graduate. And minimally, the standards are that our nurse practitioners have to have 500 clinical patient contact hours, but anything over the 500, they can supplement, they can substitute, but they like to say supplement. But it depends on the curriculum and your sites, and with graduate, it's preceptors. Oh, it's a big discussion.
Yeah, it's a really difficult question because depending on your country and your university as well, there are some norms to fit in. So that's a really complex one. But thank you for sharing the evidence that is always a path to follow. There are more questions here. For example, Guillaume from France. He would like to know, he's building a portfolio with simulation activities. It's a virtual one. So they have used that portfolio in the clinical areas, and now they are doing in the simulation area. So he would like to know your ideas about this topic, about registering with portfolios the sim activities.
Thanks for the question. I think that's a good one to consider about the portfolio. That is something novel. What I see the portfolio actually being very valuable to document. It's not just simulation experiences, but maybe it's competencies demonstrated through simulation-based evaluation or assessment. I'll give you an example. Our educational priorities are changing through American Association of Colleges of Nursing, and we are moving to competency-based education. So competencies will need to be demonstrated at the end, whether it's a pre-licensure program or a doctoral program producing nurse practitioners or advanced practice nurses. And there are 29 competencies, I'll say, like in the MPD and Doctor of Nursing Practice. Those 29 competencies, to me, would be best demonstrated through simulations. And where you standardize how these competencies are tested, then I can see that moving into a portfolio. And actually some of the times tested, it was a beginning time at the baccalaureate level and then at your terminal degree. So I think there's ways to do that. I would, in a portfolio, I don't know what that all would encompass that someone's proposing. I do think it's very important to document that, but I would lead it toward competencies versus just hours of time. I don't think, that's what we capture all the time in clinical. Oh, they need 700 hours, they need 600 hours, they need 1,000. And a lot of times the hours and time doesn't measure the quality, but competencies can be measured definitely through simulations.
Thanks. There is another question, is Mark from Germany, asking about implementing interprofessional team simulations with nurses, respiratories, physicians, etc. And there is another question real similar to that from Olivia from Latin America, that she's worried about now they are not doing clinical practice, the students of nursing. So they are worried about the nursing start working without a real experience in interprofessional. So both of them are asking you about the possibilities of using simulation for this interprofessional training during COVID. What's your idea on that?
Okay, so a couple of questions there. One, the NLN Jeffries simulation theory can be used for interprofessional. It's to be used for all different audiences. It's just a guide, a roadmap, if you will, grounded in theory and evidence. And right now, the NLN Jeffries theory monograph came out in 2016. I am updating it, and we're doing a literature search on the evidence where the theory's been used. And I will know more about interprofessional realm and how that's been used versus just a nursing discipline. I totally support, and we need to move toward interprofessional education. That is a must. We're greater in teams than we are in silos. During COVID, with the question asked, it would have been awesome to do a lot of interprofessional simulations. I can speak for the States. I can't speak for your country, but we were pretty much on lockdown, and we had a lot of virtual simulations going where warranted. It behooves us to do interprofessional simulations, but many people were scrambling because they weren't ready to move to the total remote virtual for clinical learning. And we had to do that, I think it was mid-March, March 13th, 14th, we had to turn on a dime, it's probably an Americanism, but we had to change. And much of our clinical, of course, was patient care face-to-face, even though we had some simulations immersed in the lab. But then we closed our lab too. Everybody went virtual. So yes, COVID, I think it was difficult for virtual or interprofessional unless you already had those virtual scenarios set up. But during the crisis, we were doing a lot of times it's easier to work in silos than to be collaborative. And now come fall, we have done some interprofessional simulations, so it was easier because we had months to prepare versus only weeks in March. So I advocate very, very much so for interprofessional simulations. That's the key to teach our, not only our students, but our new graduates about working in teams, team engagement. That's so important for patient quality care.
Thank you for your answers. I have two questions more. One is now that your instructors have to adapt to virtual simulation, what do you think they are the challenge that simulation instructors are facing right now and how to solve them? Because what we have felt here, for example, in my country, in Spain, we go into a lockdown in 3 days. We have normal life, then we go into a lockdown. So we have no time for prepare. And that's really, really difficult because a lot of people has a lack of skills on some virtual elements. So I would like to know how you have solved that or what you have done for facing that change of role. And I mean as well, some of us have done some videos, but for recording videos, you need to know a lot of things.
Thank you, Esther. So getting faculty developed, instructors developed in simulation, and particularly when we had to shift in March, that was a challenge. We were fortunate in my school at George Washington. Our graduate faculty had been teaching online and doing some virtual sims, even though they brought students in for sim immersion in our simulation space, face to face. But immediately, and I covered this in my presentation, we required any of our faculty that were working with students in simulations, even virtual simulations, to go through that MOOC. You saw the MOOC through Coursera.org, MOOC, the massive open online course. There's 7 online modules done by a lot of simulation leaders and experts, and that is free. So our academic leader, she required that all of our faculty go through those 7 modules, and then they were checked. They had 2 months to go through it. So that's one solution. At least you get a baseline. At least they know what simulation is. They know some basics on debriefing, and you can see what those modules are. And if you can't do all 7, select 3 or 4 that are pertinent to what you need in your program. The other thing, and I know a lot of faculty had to turn in and do simulations that they'd never done them. So a couple of other strategies there. I know there were a lot of webinars going out in 2 to 3 months time because many people were trying to learn. And I applaud the vendors and all of those. I know I did a lot of free webinars for vendors and our professional organizations. It's just to get people try to, think about this, because we all were in the same boat trying to provide instructional continuity during COVID, during lockdown, but we wanted our students to progress. I think the third strategy would be if there is a seasoned person that knows, faculty that knows simulation, kind of mentor, pair them up. But maybe the first time they run a simulation, you have a mentor with you or a champion, so they can learn from that, then kind of wean them from that. But it was hard when we had to turn, just like you folks in March, everything stopped and we had to shift. And of course, we all did the best we can and we've learned from it and we're still learning from it. But there's some things we're doing much better now than we did in March.
Thank you. There is another really interesting question. I think we have time for 2 questions more. And it is about Mariana Merino. She's asking about creating the safe container with the first year students that never have met face-to-face. So they are finding quite challenging to create this safe container for doing simulation when you never has been together with that person face-to-face. Have you had any experience or any recommendation for doing that?
Again, thank you for that question. It's outlining a big challenge that we all have, right? We admitted students in the summer, so they never saw each other face-to-face. They were all virtual. Then they come into fall and we are doing labs and clinical in the hospital or face-to-face. And what I was doing even, I mean, March 13th, just like you folks, I had a whole remote workforce, right? All my faculty and staff went remote. Many of them had never worked remote before. So as a leader, as a dean of nursing, and I would suggest this as a simulation director, as a course leader, looking at simulations and promoting, the clinical education. I think key is continue to try to build community. So you getting your students together, even in a virtual gathering, let them have their cameras on so they can see each other. Every week I had a faculty staff town hall. So we had 1 hour. I would talk about COVID. By the way, we're in week 34. I was counting the weeks, but any news coming from the university, are we going virtual? Are we going blended? What's happening? We have budget cuts, probably just like you. We have a hiring freeze. I have many people doing temporary support, and our staff did over 50 virtual gatherings for these students. They would say on Thursday, we're meeting at noon, and these are for our new students in semester 1. This is bringing our alumni in with our students. There were always these virtual gatherings to try to get to know them better. Many times there were selected topics. Like on Thursdays, I know there was always a wellness support. We talked about mental health. We talked about support. We talked about stresses, take care of yourself. It was all about health promotion. So that was always a Thursday deal. Other times there was a 5 o'clock virtual, I'd say kind of happy hour, but students could talk and get to know, oh, I live in Virginia. I came from California. So they start getting to know the community. But to me, it's building community the best that you can virtually. And I got to tell you, as a dean of nursing, I got to know my faculty and staff a lot better because I was meeting with them every Wednesday. I still do. And then that was like real information, communique. They ask questions in an open forum, just like you're doing. They put in chats. We did shout outs to, Janice, she's doing a wonderful job. Our SimOps team, they're working the virtual. And then on Friday, I had what was called Fun Fridays. That was only 30 minutes. But we played virtual games. People showed their pets off. People showed children, their coworkers. But somebody remodeled their bathroom. We saw that. It's just like we got to know our community and we're in it together. And every week we are in it together. It takes a village. It's a community. It's not one leader. It's not one faculty. It's not 3 staff. It's all of us. And my mantra was, this is very, very hard, the challenge. But what we can provide students, even though we're not meeting them face-to-face, is teaching excellence. We have to continue to provide high quality teaching, even though it's on an online platform and not face-to-face, we can still be excellent. And the second is service excellence. Service priorities, that's a priority. if somebody's calling, pick up the phone. If they have an email, respond quickly. We don't want them to sit in cyberspace for 3 days because they're very lonely in a lot of this. And then a lot of our faculty have had meetings with faculty. So hopefully that helps. This is a challenge, but doing the best we can to build that community.
Thank you, Pam, for all your experience. I think it's inspiring. I got your idea about sharing your new things at home or things like that, because being so lonely, I think is impacting in all of us. So I'm seeing we are arriving to the hour. And I would like to really thank you for being here, for helping us as a community, for helping our society, and for always being such a reference for all the community in nursing. And we expect to see you in our virtual meeting as well. So thank you so much, Pam, for being here today with us and sharing all your knowledge.
Well, thank you for asking me. I'm very honored to be here. During the presentation, I tweeted out CSAM, so thank you. Thank you, my colleagues across Europe and Chile, Argentina, Spain, everywhere. And let's keep in touch. We're in this together.
Yeah, we are working together. We will be working together. We have to support each other.
We have to, yeah.
Thanks,
Thank you.
Pam.
Have a great day. See ya.
Yeah. So for ending this day today, we just want to say, all of you, thank you for being here today with us. And we would like to invite you to join to our virtual meeting in April. We will be opening soon the registration in the following weeks, and we will have more content about nursing, about COVID, and all the hot topics that are right now in our minds. So thank you all. It has been a real pleasure to be here with all of you. Y gracias a toda la comunidad latinoamericana por estar hoy aquí también. So thank you so much. See each other in our next virtual gathering. Bye.